Hey guys, welcome back to Medical Coding with Blue. Today is Vlogmas, day 13. If you are brand new to my channel, welcome. I am Blue, I'm a medical coder. This year for Vlogmas, I am doing the entire series on modifiers. I will be leaving the playlist for the modifiers in the description box below, along with some very helpful websites. So, let us begin. I will start off by reading from the CPT Professional edition by the AMA, the Appendix A. Today's modifier is Modifier 55. Which is postoperative management only. So here we go. When one physician or other qualified healthcare professional performed the postoperative management and another performed the surgical procedure, the postoperative component may be identified by adding modifier 55 to the usual procedure number. Okay, so yesterday in our example of modifier 54, a patient is from Omaha, Nebraska, and they are visiting Las Vegas. And they slipped and fell and broke their wrist. Well, while there, the doctor says, okay, well, I'm going to go ahead and treat this with a closed treatment. So they put a cast on them, and then when they go back home, they tell them that you need to follow up with an orthopedic group. So the patient goes home, and the first visit with the doctor that they're going to see in orthopedics, most likely, right, will look at their fracture and go ahead and see if it's still set right, if they need to go ahead and recast it. But for that visit, the provider will have to know what procedure was performed. Hopefully, the patient brings along with them their note so that they know what procedure was performed. So with that, they will have all of the information needed. So they will have the date that the surgery occurred, and they will also know what procedure was performed. So they need to have the exact procedure that was performed so they can put a 55 modifier on that. And that is what that provider will be reporting in Omaha, right? They will be reporting the closed treatment code, the procedure code with that 55. That says to the insurance company, I am just taking care of the post-operative period, okay, for this patient. I did not perform the actual surgery, but I am performing the post-operative period. So that is how you can make that distinction between the two. So let me go ahead and read from NOVITAS, the NOVITAS website, which has a wonderful co-management article about modifier 54 and 55. So we'll go ahead and get into it. All right, so post-operative co-management, modifiers 54 and 55. Global package. Physicians who perform the surgery and furnish all of the usual pre- and post-operative work should bill for global surgical care by using the proper CPT surgical codes or code. In this situation, physicians should not bill separately for visits or other services that are included in the global package. No modifier is necessary. When different physicians in a group practice participate in the care of a patient and the physician reassigns benefits to the group bills for the entire global package. The physician who performs the surgery is also known as the performing physician, and no modifier is necessary. What they're saying here is if a provider, like the surgeon, goes in, does the surgery, and a PA, a physician assistant, in the same group sees them in the post-operative period for their dressing changes and you know, if they have to have like a cast change or whatever, and they're seeing, the PA is seeing them in the post-operative period, it is still considered part of the global package, and they are not going to bill separately for their service. The PA will not do that because it is included because they are part of the same group. The difference with my example is the attending surgeon is the one that was from Las Vegas, and obviously not related to the practice or the group that is in Omaha, Nebraska. So that is how we can separate and think separately in this process. So co-management. Occasionally, a physician must transfer the care of the patient during the global period. In these instances, the use of the modifier would be necessary to distinguish who is providing care for the patient. NOVITAS expects these instances to be rare. Okay, obviously, if a patient is vacationing and they hurt themselves, this would be a good example of this, right? Reasons for splitting care. The operating surgeon is unavailable for surgery and the patient's postoperative care has to be managed by another physician. Another reason for splitting care, the patient is unable to travel the distance to the surgeon's office for postoperative care visits. Clearly, a vacationing patient is not going to go all the way back to Las Vegas, even though I'm sure that they would want to, because I know I want to. I miss Vegas. Anyway, they're not going to travel all the way back over there when they live in Omaha, Nebraska. Okay, the care is provided in a health profession shortage area, and the patient is unable to travel to the surgeon's office. The surgeon practices in a site remote from where the patient recuperates. Example is the surgery is performed in a remote area and the surgeon does not return to the area frequently enough to provide preoperative or postoperative care. Makes sense, right? The patient voluntarily wishes to be followed postoperatively by another physician. Or another reason for splitting care is the surgery is performed by an itinerant surgeon in a remote part of the area or of the country. Transfer of postoperative care is not covered if, okay, the operating surgeon is available and he or she can manage other patients postoperatively unless the patient voluntarily wishes to be followed postoperatively by another provider. Transfer of postoperative care is not covered if the surgeon does follow the patient postoperatively, but splits the fee with another provider. 2 or more physicians co-manage patient indiscriminately as a matter of policy and not a case-by-case basis. Also, transfer of postoperative care is not covered if the physician demands to manage the postoperative care and indicates that he or she will withhold making referrals to surgeons who will not split global surgery payments. Drama. Postoperative care is not covered if the surgeon opts to transfer postoperative care. The transfer is not made in writing. This is why documentation is very important. The documentation from Las Vegas should read that the patient lives in Omaha, Nebraska. They will be having their follow-up care there and that they are essentially just performing the surgical procedure. It needs to be clear. It cannot be, oh, okay, well, yeah, they'll get it. No. It needs to be documented that the patient lives there. And obviously they are not going to come back for their postoperative care. Okay. The transfer of care is used as an incentive for obtaining referrals from providers to receive postoperative care reimbursement. Also not, postoperative care is not covered. Okay. And then finally, postoperative care is not covered if the patient has not consented to the transfer of care, even after being apprised of the medical and or logistical advisability or the risks and benefits of transfer of care. So again, the Las Vegas provider would need to make that clear to the patient about how this is split up and that it needs to be okayed with them as well so they can be part of the process. So it's not like, okay, well, what's happening here? Am I getting double billed? Okay. They don't want to do that. So you want to make sure that everything is clear. Okay. And this is a good time to educate your providers about this. Surgical care. Specific billing guidelines must be followed when the surgical procedure and postoperative care is split between different physicians. Modifiers 54 and 55 are used to indicate 2 different physicians are rendering the surgical care and postoperative care management services. Where physicians agree on transfer of care during 10-day or 90-day global period, the following modifiers are used. So they need to talk to each other as well. 54 is for surgical care only. 55 is for postoperative management only. Physician rendering 1 day of preoperative care, intraoperative services, and any inpatient hospital visits. Bill services with the date of surgery. This is why it's always important, guys. You've got to watch this stuff. Date of surgery, procedure code for the surgery, 54 modifier to indicate that the bill is reflective only of surgical care. And if the physician who performs the surgery relinquishes care at any time after the surgery, the date of transfer of care must be indicated in item 19 or the equivalent for electronic submission. So again, with billing, you need to make sure that it's properly inputted so that the insurance company gets it. So this is one of those things that they're talking about here. Post-operative and / out of hospital care. Bill services with the date of surgery, the procedure code for the surgery, and the 55 modifier. In the case where the surgeon also cares for the patient for some period following discharge, the surgeon should bill the surgery with a 55 modifier and indicate the portion of the post-operative care provided in addition to the surgery with a 54 modifier to indicate the intraoperative service. In those cases where the post-operative care is split between physicians, the billing for the post-operative care should be reported as follows. Report the date of service using the date of the surgical procedure. Report the procedure code for the surgical procedure followed by the modifier 55. Report the date the post-operative care began and ended, along with the number of post-operative care days in the narrative field on electronic claims or item 19 on the CMS 1500 claim form or the electronic equivalent. When there is a transfer of post-operative care, Medicare regulations require a written transfer of care agreement between the operating surgeon and the physician assuming care. So there needs to be that communication, like I mentioned. Both the surgeon and the physician or physicians providing the post-operative care must keep a copy of the written transfer agreement between the beneficiary's medical records. Where a transfer of post-operative care occurs, the receiving physician cannot bill any part of the global services until he or she is provided at least one service. Once the physician has seen the patient, that physician may bill for the period beginning with the date on which he or she assumes care of the patient, using the surgery date as the billed date of service. This is why those dates need to be in the documentation. Both bills for surgical care only and postoperative care only must contain the same date of service, the same surgical procedure code. This is why I say that procedure code needs to be clear, okay? And the appropriate modifier. Note, providers must report the date when postoperative care is assumed for another provider, including the date post-operative care began and ended, along with the number of post-operative care days provided in the narrative field on electronic claims, or item 19 on the CMS 1500 claim form. This will facilitate processing the claim and reduce unnecessary rejections. Example, physician A performs a hysterectomy, 5/8/150, in the hospital on April 15th, 2021. The procedure has a 90-day global period. The patient was in the hospital for 8 days until April 23rd, 2021, during which time physician A administered postoperative care. On April 24th, 2021, physician B took over the postoperative care, which was administered in the office. And it gives a very nice breakdown of how they, the example of how they should bill. Okay, so it shows you the 54 and the 55 in action. And then it says, we edit claims to ensure split postoperative care claims contain the following: the date of service, the date equals the date of surgery, and then item 19 or electronic equivalent is the date postoperative care began and ended, along with the number of postoperative care days provided. Again, I will be leaving this link so that you can see this wonderful graph in the description box below. Claims that do not contain the above information will reject. So again, it's very important that all of these bases are covered. And then it goes into payment calculation, which I won't read because it's too much. but I want you guys to be able to check it out when you do have a chance. And then documentation requirements going to close out this article. So documentation requirements. The surgeon should write usual operative note, and the physician providing postoperative care should document appropriate follow-up care notes. Transfer of care must be in writing and dated. The record must indicate the exact date in which postoperative care is assumed by the co-managing physician. Medical record must indicate that the patient was appropriately informed of the medical and or logistical advisability of transfer of care, along with any risks or benefits of this arrangement, and that the patient gave consent to this arrangement prior to its inception. All documentation, including the documentation that the patient was properly informed, must be available to Medicare upon request. So the details matter, and you have to be very detail driven in this field. Whenever I see postoperative notes from my providers, even though there's not this split thing going on, even though there's no instance of 54 or 55 happening, I always tell them, even when they are in the postoperative period, I need to know what date of service, what date did this patient have the surgery. And it needs to be in their postoperative notes, because this way I can accurately keep track of what day they are on. I don't have the luxury of being able to go back and look at other notes because I'm in the outpatient setting. Now, the only time that this would be allowed would be if you are in the inpatient side and you're working with the entire record. On the outpatient side, we are working with what is in front of us on that date. We are not allowed to look back on any notes, any prior notes, to see what's going on or to try to get this or to get that. Everything needs to be documented on that date of service, what's going on, what happened. And I've made this very clear with my providers, and thankfully they have gotten on board with this. So they do tell me what date the patient had the surgery. They don't have to tell me how many days because I can count, but I do need to have that date of surgery in the notes so I know how far into the postoperative period they are. But that is a good lesson in Modifier 54 and 55. This is why I love NOVITAS. Anyway, but yes, so guys, don't panic. It will get easier. I know I keep saying that, and it will. As you practice and as you get into these modifiers, you will start to understand, and really digging in and finding good resources like NOVITAS is very helpful when you are trying to learn this stuff. So the sharper you are, the better you are for your provider. So anyway, I'm going to go ahead and wrap this one up. I hope you have enjoyed this. Don't be shy with that like button. Please like, please subscribe if you haven't already. Please share this if it helped you. And I will see y'all on the next episode. Bye.